Hey everybody, welcome back to the ECG of the day. My name is Reed, and before we get started, if you would like, you can go head down to the description and download the PDF of today's ECG, this document right here, so you can follow along and make your own notes. And um, if not, please consider liking this video and subscribing to the channel. And yeah, let's jump into it. So first thing I like to do is look at what I call the forest, and the trees of the forest are my QRS complexes. And so I look down, maybe I just pick a rhythm strip and sort of get an idea of what's going on. What you'll notice is I've got these narrow complex beats followed by these wide complex beats, and that kind of happens over and over. Narrow, wide. My narrow beats, you can see, have a nice P wave followed by a nice QRS, and then we have these funky beats, right? So narrow, wide, and if you just follow that all the way through, you see that we maintain that pattern. You can see that those funky beats are premature. So this is a premature beat, right? They should, I would expect that my next beat, if I draw kind of a line between my R to R's, to be right here in the middle, but you can see that one comes a little early. So we've got these premature beats that happen every other beat. And we know that premature beats that happen like that, it's a pattern. It's called bigiminy. And bigiminy can happen from the atria. Atrial bigiminy would be a premature atrial contraction that conducts every other time. And we have ventricular bigiminy, which is a PVC, a premature ventricular contraction to every other beat. And so bigiminy really is just something's happening every other beat here. It's premature. And so we'll take a look and maybe see what type of bigiminy that we're dealing with. So the first thing I'm going to do is evaluate my atrial activity, and that's my P wave. I can see I have P waves throughout. My P waves are upright in lead 1. They are upright in AVF, right, when they occur in front of my narrow complex rhythms. And so that tells me that these are sinus P waves, right, if they're heading down and to the left, which is lead 1 in AVF, or my down and leftward leads. And so I've got this sinus rhythm. If I want to calculate the rate, it's kind of hard because we've got this bigeminal pattern. So you can count, sometimes I'll just will count how many QRSs are in this ECG. It's a 10-second ECG, right? So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 15 in a 10-second clip. So you can do 15 times 6, and 15 times 6 is 90. So this is a rate of 90 beats per minute, and so it's normal rate. And so that's my kind of get an idea of what's going on here. Let's take a look at what my AV node is doing with the PR intervals. We see that my PR intervals, if I look here, are within 120 to 200 milliseconds, so my PR is normal, right? We want that to be within 120 to 200 milliseconds. So I've got a normal PR interval. I want to scan through and make sure my PR intervals remain that way the entirety of the rhythm. And you can see that that's the case. I can just kind of scan through my PR intervals, and they look like they stay the same. AV node is behaving in a similar fashion the entire time. We can evaluate the QRS complex of our narrow rhythm here. We'll evaluate the QRS of our wide complex here in a little bit. You can see that my QRS for my narrow beats that occur with my P waves are upright in lead 1. They seem to be isoelectric in AVF, so perpendicular to AVF, so it looks like the axis of those is probably straight towards lead 1, which is like a 0 degrees on our, if we want to quantify it. So it's a normal, it's like a leftward but normal axis. We've got a normal QRS axis, and then we've got maybe some poor R wave progression. You can see it takes a little bit of time for the R wave in my anteroseptal leads to finally transition, which happens here V4 to V5, where we start getting more positive forces there. So we can evaluate that later and see if there are any pathological Q waves. For my QT interval, you can calculate it based off of the rate here, but if you kind of eyeball it, the QT seems to be okay. You always do run the risk of, if there's a premature ventricular contraction that is getting close to that QT interval, if the QT interval is long, then you get a little bit worried, right? If you want to know how to correct for the QT interval, because the QT interval is going to change with rate, you got to have a rate correction, which is the QTC, is the QT interval divided by the square root of the R to R interval in seconds. And so the square root of that. So what that's getting at is when the R to R interval in seconds increases, our corrected QT interval is going to decrease. And so you can correct for the QT. If you would like, you can measure it out and get a rep here. I don't think the QT looks very long. And so now we're going to just look for pathological Q waves and ST and T wave changes associated with our narrow complex rhythm. The only thing I really see here is maybe some loss of our septal R waves here. So maybe, is there a prior septal MI? You know, potentially, right? And so you gotta maybe look at the history of our patients. Maybe a prior septal MI because we have these deep Q waves in our septal leads, which are V1 and V2. And so now let's figure out what's going on with these premature beats. We know premature beats that are wide are suspicious for a ventricular complex because the wider the rhythm, right? If we have a rhythm that's a premature beat coming from low within the ventricles that fires off and it spreads from cell to cell, gap junction to gap junction throughout the entire ventricular system, it's going to take a long time. It's going to be a wide, complex rhythm. And if you look, the one thing we want to always rule out is that this is a premature atrial contraction that conducts aberrantly through the ventricles. And so you look in front of these QRS complexes to see, is there any evidence of atrial activity buried within the T wave? And V1 is a great lead to look at because our T waves are usually nice and kind of rounded and gentle, kind of flatter as well. And we know that atrial activity is usually a little bit more sharp, right? Look at the P waves here versus my nice and gentle T waves. And so I don't see any evidence of an atrial activity that might have triggered this event. And so these are premature ventricular complexes. And so this would be ventricular bigeminy. This tells me that every other beat is a premature ventricular contraction. So that's what this person has, right? And they all are monomorphic. They come from the same region, right? And every lead, they look the same every time. And so if you want, you could even map this out and determine maybe where in the ventricles do you think this would be. And so you can see that they are all upright in my inferior leads, which are leads 2, 3, and AVF. All of my premature ventricular contractions are positive, meaning that they're heading towards the inferior leads. So likely, if we wanted to even map this out, it's probably coming from somewhere that is kind of high in maybe the left side, right? Because we've got negative AVL, so it's going away from AVL, but it's going towards the inferior lead. So maybe it's heading in that direction, right? And then you can actually do an electrophysiological study. And so that's our rhythm. Let's put this all together. What do we have? We've got a sinus rhythm. The rate of the rhythm is 90 beats per minute. We've got ventricular bigeminy and some evidence of a prior septal myocardial infarction, which is evidenced by Q waves in the absence of any real significant positive forces, which tells me that the septum here, represented by V1 and V2, is unable to conduct signal towards that direction. So I hope this helps. If you have any questions, feel free to throw it into the comments. If you enjoy these videos, I would appreciate if you subscribe so that we can kind of get the channel out there and keep making ECG videos. So have a great day. See you tomorrow.